Hello and welcome to our podcast, The Doula and The Doc, hosted by Vanessa Salerno, a birth and postpartum doula.
As well as Dr. Joseph Scroy, an obstetrician, gynecologist and fertility specialist.
Together we'll be discussing a range of topics from preconception, pregnancy, birth and also the postpartum period.
Together we combine holistic insights and medical expertise. We dive into women's and men's health with honest information and sometimes the unexpected conversations.
This podcast is where evidence meets experience, so let's start the conversation. Please note the information provided in this podcast is for educational and entertainment purposes only and is not intended as a substitute for professional medical advice, diagnosis or treatment. Always seek the advice of a qualified healthcare professional regarding your own pregnancy, birth and health-related conditions.
This season of The Doula and The Doc is brought to you by Libra.
Welcome to the Libra Odd Spot.
Yes, if anyone knows when you are in the bathroom and you are taking out your pad, we have odd spots and we love to sit and read while we're in the bathroom.
So stop scrolling and start reading.
The Beatles used the word love 613 times in their songs.
Love, love, love. The average pencil can draw 56-kilometre line. Well, welcome, Laura, to this wonderful episode. We're going to explore the pelvic floor.
Thank you for having me.
Its majesticness and, of course, how it helps with, what happens during the whole process of pregnancy, what happens in terms of birth and what we have to do afterwards in order to help with the pelvic floor. And also, I suppose, what a physio does during pregnancy.
It's pretty important, I'd like to think.
Absolutely.
I definitely encourage everyone to come see physio, specifically a pelvic floor physio in pregnancy. I suppose your pelvic floor is having to do a heck of a lot. Its main role is to keep everything closed and keep everything lifted. And of course, as pregnancy progresses, that's increased weight down into the pelvic floor. So strengthening that muscle becomes so important.
And I agree. And part of the thing that I always say to women who are coming for their first pregnancy visit to see me, and one of the reasons why we work so closely together in our rooms, is that it's also about helping prevent in the future things like pelvic organ prolapse and also incontinence, which are particularly important and difficult really to think about when you're in your 20s and your 30s having your babies, for something that potentially might happen in your 40s and your 50s. But knowing that what you do now prophylactically is going to be important for what's going to happen in the future.
Absolutely. It's almost a challenging conversation to be having when you're in the moment of pregnancy and we're talking about strengthening your pelvic floor, to then be thinking, what you do now is going to impact, when you're 40, when you're 50 and when you're going through menopause, to then, whether or not you become symptomatic, whether or not you then experience a pelvic organ prolapse at that point.
But the pelvic floor, you would say, is important even before.
Oh,
because you can get incontinent not
Absolutely.
even having or thinking about having a baby, right?
It's definitely not my area, but like pediatric incontinence, pediatric constipation definitely has some pelvic floor involvement.
Yeah.
And a lot of the women that I'm meeting in pregnancy may have already engaged with pelvic floor physios when they were teenagers, painful intercourse, discomfort with internal assessments, can have a pelvic floor involvement. And that's definitely something we unpack, particularly from a pregnancy and a labour perspective, because that may also influence that.
So maybe we'll talk about that beforehand, because some of the times I'll see women who come to see me because they have endometriosis and they might have pelvic floor dysfunction and also pelvic myalgia, which is where you get increased tone in the muscles within the pelvis. And that may be the first engagement they have with a physio. So can you walk us through the mechanics? In fact, what I tend to say is, I don't know if any of you do bicep curls, but if you do bicep curls like I'm trying to do at the moment, if you do bicep curls and you don't extend your muscles all the way out, right? So you don't extend to do your bicep curls. If you leave them halfway, then you get this ongoing tension within your muscles.
Yep.
And that causes pain.
Yep.
And often what I say is when you've had endometriosis, the mere fact, but potentially when you're having sexual intercourse, that there's a pain response because of this deep pain that you get when you have sex, that your pelvic floor then acts to activate to try to prevent that pain from occurring. And that can lead to what we term like you've got deep pain with sexual intercourse and you've got very superficial pain. So this pain that happens just at the point in time that you're having entry into the vagina with sex. So can you walk us through the mechanics of what's happening to the pelvic floor with endo or pelvic myalgia And then we'll move on to the pregnancy sort of stuff.
I mean, I always like to think about pain as a bit of an output from the brain. So your brain gets to work out how intense is that pain response or how dulled is that pain response. As an example, let's say you're running through the jungle, you fell over, you broke your ankle. That would typically hurt. If you're walking down the street, that would hurt like hell. However, if you're being chased by a lion, a tiger, you're going to sprint until you're in a safe space to then think about that pain. So in the context of endometriosis, or even sometimes that might have a flow-on effect to bowels or bladder, your pelvic floor is that secondary response that there's always been pain in the area. So it goes into that reactive state of seeing like it's tense, it's on guard, it's trying to protect you because it doesn't know actually what's that pain stimulus at the time. So therefore you go into protective spasm. And until you address what that pain is, whether again it's bladder, it's bowel, it's endometriosis, you're still going to have that constant pain response.
Absolutely. And I think, often when I'm seeing women who've got pelvic pain, particularly for pelvic floor pain, I'll do an internal examination. And, the vagina is the inside part of what's inside, right? Obviously the vulva is on the outside, but surrounding the outside are muscles, and those muscles can be really tender to touch if you just put a finger on it, bang. And also inside the vagina, imagine the vagina is almost like a skivvy. If you put your finger inside the skivvy and just go from one side to another and press, there's these muscles that are there on that side supporting the vagina. They can be pretty tender as well.
Yeah.
So in terms of the I think it's a very intimate examination, but what should women expect when they're seeing a physio in terms of what you're doing in order to assess the pelvic floor?
So generally that first assessment or that first appointment, a large part of that is just chatting, getting to know what your medical history is, your story. So we will dive really deep into your bladder, your bowel. So how often you're going to the bathroom, what's the consistency of what you're passing, do you push, do you strain?
You're all about the poo, aren't you?
All about the poo. It's honestly can solve so many things. Bladder, how many times you go into the bathroom per day? Is that ever uncomfortable? Do you ever feel like you don't empty completely? So really diving into that, but then as well, like what's been your experience with either intercourse, internal assessments up until that point, and often you will start to pick a pattern and you'll start to put a bit of a clinical picture together.
Because not everyone will want an internal.
No, and there definitely are less invasive options for that assessment that we always give people the opportunity to pick what assessment they feel most comfortable with. But the gold standard assessment would be an internal assessment, and that just gives us the most amount of information. But as I said before, we don't want to cause pain in the area. So if an internal assessment is uncomfortable, I'm not going to proceed with that because that's just further feeding into that painful experience. So we're trying to desensitize that area. We might only start external, and that's where we got to for that day. Send them home with homework to address that.
Do you think they do? Can you tell when someone's doing their homework or not?
Yeah.
So can we work through just what's involved in an internal assessment?
Yeah.
So essentially, I would start external. I'd be looking at the tissue and the skin, the vulva. If they've had a history of pain, I may use a light tissue just to brush the area and see, does that cause them a pain response? Ultimately, a tissue touching your external skin shouldn't be painful, but if it is, that tells me that they have a heightened response to pain. But then we'd move into that internal assessment. So typically for me, that would involve a single glove finger insert into the vagina, and then I am slightly putting a bit of tension from side to side. Is there tenderness? What's the tone of that muscle? But then I'm grading strength, endurance, coordination, relaxation. Other things I look at is what's their push technique. So particularly in that pregnancy population, can they actually distend their pelvic floor and lengthen it past that neutral position? But also taking a measurement, which we call your GH plus PV, which is looking at the genital hiatus, so from your urethra to your vagina, plus that perineal body, and that in itself can give a really good indication of what someone's risk for prolapse is.
Okay. Do you find that most people don't know how to turn or turn off that muscle when you're doing that examination?
Some people have a vague idea, but it can use some refinement. They may tend to just use sort of what I would call like a back to front movement as opposed to that all around occlusion. Yeah. For some people, they'll create a bear down or a push. For other people, it's all glutes, it's all abs, but the pelvic floor is doing nothing. I know you know, from the research, about 60% of people do it wrong. It's not as easy as your quad or your calf that you can sort of, you know, just do a knee extension movement and you can see it.
What made you go into this part of physio?
Like, that's my most commonly asked question.
Well, I've never asked it. I'm going to ask it today.
I think like every physio, I went into it thinking, you know, I wanted to go down that sport path, work for a footy team or anything like that. But
yeah.
What football team?
St Kilda.
Yeah.
If you've read the
Wrong
papers
choice.
today, it's not great.
Oh, I have to read the papers.
But I think in the sports world, all you're working on is like the immediate, right? Can you get out on the field? Can you get up for the rest of the season? There's no long-term discussion or insight into like, okay, well, what happens in 5 years and 10 years and 20 years time? I feel like if you look at most footballers, they don't necessarily have the greatest joint health down the line.
It's always interesting. I was unofficially the Carlton female AFLW gynecologist for a little while.
Yeah. Did not know that.
Yeah, didn't. So I saw a few of the Carlton female AFLW players. And one of them, a very famous one, came and saw me with what appeared to be, or what they thought was endometriosis. So the physio came along to her appointment, actually, for what she thought was endometriosis type pain. And anyway, I examined her, I did an ultrasound, I did an internal examination, and I pressed on her suprapubic area, like on where the pubic bone fuses together, and she jumped in pain. Like it was very. I was sitting there going, "Am I missing something here? Or was this sports physio coming to see me for endometriosis pain?" And I reckon this female athlete's actually just got osteitis pubis, right? Yeah. And I just pressed on. She went, that's exactly the pain. I think to myself, well, maybe I was a sports physio, you know. I shouldn't be picking that. I'm not a sports physician, right?
But maybe there's a pelvic floor involvement.
There was. Well, I think there partly was. There was a response. But she was running these long distances, and then towards the latter part of the run, she would start seizing up in pain. I mean, it seemed to me that there was you're right. She was probably getting a bit of pubic tenderness, and then her pelvic floor overacted. Tell me, in terms of pelvic floors,
yep.
I mean, obviously, if we're trying to strengthen the pelvic floor, because we've talked about pain with the pelvic floor,
yep.
But if we're trying to strengthen it, how often and who should be doing pelvic floor exercises?
Everyone.
Yes, everyone should be doing it, but as long as it's specific to you.
Okay,
right?
yeah.
So even to what I would call like down train a pelvic floor. So if you have that more high tone, painful pelvic floor, you still want to do pelvic floor exercises, but the emphasis will be on that relaxation in between each
Well,
rep.
you hear that like you should do it at the traffic lights.
No, I don't like that.
You don't like that?
You don't
10
like
times
that?
every traffic light.
Yeah, but you wouldn't go and just do like 10 squats every time you walked up to a pedestrian light if you
Maybe
wanted to
he
actually
would.
strengthen your glutes.
I do.
But if you were
every
actually
egg collection I do 10 push-ups.
for what reason though?
Just because it's my routine. And also,
Because you're actually trying to strengthen
Give
up
you
through your
that
pecs
bice-
and your shoulders, or because
yeah,
it's just for
absolutely.
fun?
Or a bit of both.
I suppose if you're just doing 10 random reps here and there, you're not creating any progressive overload.
But do you think that that's subconsciously for them to go, oh, shit, I've got to stop and do it?
I just realised how much you swear in this podcast, and I apologise to everyone out there who doesn't like the words.
Potty mouth.
Yeah, absolutely.
I have to keep it real. The two of you are very
Do you
like...
think shit is a bad word?
Put it this way, it's becoming a lot less. Well, you can say a lot of words now, can't you?
It's true. Anyway, what I was going to say is that people then go, I have to do it now because life is so fast-paced. We don't have the time to go, I have to do my math. Do you know what I'm saying?
Yeah, but I think that's an excuse.
So you need
it's
to
an
you need
excuse,
to
but,
dedicate
like,
your time. Yeah?
Ultimately,
Yes.
if I'm getting you to do pelvic floor exercises, generally I'm going to want you to fall in that 8 to 12 rep range for 3 sets. If you're holding for 3 seconds, releasing it for 2 seconds, we're talking less than 5 minutes for you to do your actual pelvic floor at once.
Yes.
It's not 45 minutes going to the gym. So time-wise,
When I asked
not the greatest
my
excuse.
clients, she's like, Laura's giving me exercises. I said, okay, and how are they going?
Sometimes.
Yeah.
I will say habit stack it. So brush your teeth, make dinner, something where you can still like do it simultaneously.
Yep.
It's like I say to my dentist, right? He goes, you got to floss, mate. And I go, yeah, right on. Do you floss every day? And he goes, yeah, I floss every day. He's Canadian or American, something like that. So the question to you is, do you do your pelvic floors every day?
I actually do, but I do a lot of Pilates. So therefore,
Right. Okay, so you're actually a good girl.
yeah, I am.
All right, fair enough. But okay, so we got to do them.
That's because you know the stats, right?
Yeah, I know the stats.
So what are the stats? Like regarding like incontinence and...
Incontinence is common, but doing your pelvic floor exercises can reduce leakage by 63%. in pregnancy.
Yeah.
1 in 2 people postpartum will have a prolapse regardless of delivery. So
I think that's the other misconception, isn't it? A lot of
Yes.
women will come and see me and they'll want a cesarean section, and purely on the basis that it's going to prevent them having pelvic organ concerns. And I'll say to them, Caesar doesn't necessarily protect you against that. And I use, and I'm sure you remember it as well, but I use that model of, you imagine you've got a ship in a dry dock. And if you've got a ship in a dry dock, and if you know what a dry dock is, it's where the ships are all put into a dock. And then, obviously there needs to be maintenance on the ship, yeah? They need to be able to paint the hull of the ship. So what they do is they remove all the water, and that allows them to get in and underneath the ship to paint. But if you've got the ship that's attached to ropes on the side of the wharf, and then the water slowly goes out of the dock, you can imagine the ship then sinking down and pulling on those ropes. And the mere fact that you've got this baby's head that's sitting on your pelvis for such a long period of time, irrespective of whether you're having a vaginal birth or not, means there's going to be stress and strain on the ligaments that support the uterus.
Yeah.
So you're not necessarily going to avoid having a prolapse or incontinence issues purely on the basis that you've had a cesarean section.
Yeah. I mean, the risk factors for prolapse of pregnancy. So again, regardless of delivery, chronic constipation, chronic respiratory conditions, then you'll go into potentially more birth-related stuff. But those 3 things, someone can be really blocked up in pregnancy, just be pushing, be straining, not realizing that they're causing any harm until down the line.
All right, so we talked a little bit about what happens in pre-pregnancy stuff, pelvic floor dysfunction in terms of pain, but let's talk more specifically then about pregnancy. So if I encourage all the women who are birthing through our practice to see you at 17 weeks. What are the sort of things that you will go through them at that initial 17-week assessment?
So that initial assessment, as we said before, is a lot around pelvic floor, getting an understanding of their history, ideally doing a pelvic floor assessment, getting them started, set up on a program that they can do. We will then obviously check back in down the line. But then I also have that more background in general physio, so making sure we're avoiding aches, pains. Pelvic girdle pain is so common in pregnancy.
So common.
I guess I find much probably like leakage, it sort of gets normalized. So is back pain, that people just think that's something they have to put up with. It's part of pregnancy, but it's not. So trying to chat to them about strategies to avoid that, wearing particular leggings, particular pillows that can be helpful, but obviously exercise is such an important aspect of pregnancy as well.
It's interesting too, because people think because they're pregnant they need to stop.
Yeah, stop exercising.
Yes,
absolutely.
Yeah.
I mean, a lot of women and people who are pregnant say to me, can I continue to exercise when I'm pregnant, or particularly in the first trimester? And I tell them, one of the Williams sister won the Aussie Open having been pregnant, and Jana Pittman was still running at 36 weeks pregnant. My wife was doing body pump, body attack and doing burpee push-ups at 39 weeks. I mean, I think, yes, you do need to keep physically active. One of the things you shouldn't do, though, is sort of like do stuff that you've never done before.
Within reason.
Yeah, exactly. Gradually build up to that.
Yeah.
So what are the things that, in terms of a pelvic floor, you need to concentrate, and maybe your own fitness you also need to concentrate during that whole pregnancy period?
I mean, if exercise itself, it's recommended that you keep up the same guidelines, the same exercise that you would outside of that. So the general recommendation for exercise is 150 minutes of moderate intensity exercise per week. That generally equates to 30 minutes a day. But ideally for pregnancy, you're including 2 resistance training exercises per week. That could be Pilates, that could be gym, something that's actually starting to build more of that general muscle strength.
Yeah.
That in itself can be really helpful for obviously avoiding excessive weight gain in pregnancy, but helping to manage the likelihood of gestational diabetes. It's just so important. But I think as well, like, pregnancy is so physically demanding on your body that if you sort of, throw up the white flag and stop exercising at 15 weeks, there's a heck of a lot of pregnancy that you're not exercising. And not only is pregnancy physically demanding, but so is postpartum.
100%. And I think people will say to me, I need to be fit for birth.
Yeah.
They'll say to me all the time, I need to be fit for giving birth.
Well, it's a bit like running a marathon. Yeah, you can't
Yeah.
just automatically just get out on the track and run 40 odd Ks.
Yeah.
Yeah.
You've got to build up to it, don't you?
Yeah, and I think, for a lot of people, first trimester isn't the greatest. Maybe they're not necessarily, nauseous or vomiting, but they might just feel so tired. So often we write off that first trimester in those cases, but that sort of feeds into like it's a marathon, not a sprint. If you miss 12 weeks of doing much, there's still a fair chunk of time to work on it.
As much as, she's seeing, our patients, myself and Laura liaise quite a lot based on her examinations, and what they've discussed are based on their pelvic floor. So when I'm in the birth space, I know how to work with their pelvic floor. So we talk about if they're needing an epidural base, not because they're not working at it like a champ, but based on their pelvic floor and things like that. I'm also having that chat. Laura's having that chat. Laura comes back and chats with me about it.
Sometimes you pop in.
Absolutely. I mean, look, there's differing opinions on the use of epidural with overactive pelvic floor. What's your take on it?
I think it can be beneficial.
Yeah.
I definitely think that it can be. There's some talk on it actually helping from a birth perspective because you can, I suppose, push with a bit more control, provided you haven't gone too crazy with the epidural dosage.
So I'm a big believer, and I'm very fortunate enough to be able to care for around 330 women during their pregnancy and births every year, and then obviously see the outcomes of those births. And I always say to women that your pelvis is a little bit like a basketball hoop, and your pelvic floor is like the netting of the basketball hoop. So if you're about to do a slam dunk, and along I'm there holding the netting really tightly, if you're trying to do a slam dunk, that basketball's not going to drop. It's just going to sit there and not drop through the basketball hoop. However, if you relax that, if I stop pulling on the netting, then that basketball will go straight through. And I sort of liken that, particularly when you've got a really overactive pelvic floor, as the uterus is trying to bring that baby's head down and facilitate rotation and lengthen out that pelvic floor, and there's overactivity, then that's going to prevent the baby's head coming down and also prevent potentially labour progressing. And so often in that regard, I'll advise maybe an epidural will be better, relax the pelvic floor, allow the baby's head to come down, rotate around into a position where the baby can be easily born. And, invariably, Vanessa's been witness to it several times where that's occurred, and it's been beautiful. And again, that rewarding experience of being able to get to the end, not tired, and not exhausted, because, that pain response that you talked about before, that initial pain response, you're running away from a tiger every time you have a contraction, and then your pelvic floor starts going, oh.
Yeah. But it's also when Laura will communicate with me, that she'll say that like their tone of release and certain things. So then when I'm in that birth space, it's not like they're working at it, like their breath work is beautiful, but they'll say to me, Ness, I know I'm still holding.
Still holding tight.
And so that's when
and I've potentially told you, like, use this specific cue for this patient because it's going to work really well.
Yeah.
But I think, sometimes that epidural gets demonized publicly.
It does.
And it's, I suppose, that delineation. It's not necessarily that you're not coping with the pain, but it is just going to benefit your labour.
People see it as because I've had an epidural, it didn't have a natural birth.
And look, it's interesting you say this, Ness, because my daughter at the moment's studying at ANU, and one of the classes that she was taking was a health education class, and the lecturer, I was listening to what the lecturer actually said, and she talked about normal births and artificial births. And the narrative of starting that, particularly to young impressionable women who are just starting out on their health journey in terms of this health sciences course up in ANU, I was mortified, and the way she.
What did she think listening to that?
Yeah, well, Kiara obviously knew that's because she knows what I do. That's
right.
just really wrong. So the way she talked about episiotomy, the way she talked about cesarean section. I mean, she showed photos of a Caesar scar going up and down. I mean, we rarely, if ever, have to do an up and down cesarean section. So
have you done any in your whole time?
I've had to do them because of a complication with respect to, like, for example, where we know the placenta's adhering to the uterus. I've done one in my whole practice. So the reality of the situation is that occurs really infrequently, yet that's what was being promoted in a health science class. But nonetheless, I mean, I think you know,
Wow.
the whole idea again is not be building this fear paradigm. It's about trying to support women to have that successful birth experience that they want, whether it be cesarean, whether it be a vaginal birth.
But even nowadays, it's like elective or emergency. Doesn't necessarily mean the emergency was like,
Well, I call it unplanned.
yeah, I like that.
I call it unplanned because it's, you know, it's not elective and it's veered off. And when I take away the word emergency, because generally we're not like rush, and we're
Correct.
running down the hallway. And that's
Correct.
why I say it's just the terminology that unfortunately it's used within the hospital. They look at their discharge saying that it was an emergency, but in their head they know it wasn't.
It was unplanned.
Yeah.
So we're then in the throes of pregnancy. We've talked about all the musculoskeletal stuff that we can do. But in terms of the pelvic floor, then what's the mainstay of things that we need to do?
Strengthen it.
Strengthen.
Yeah. Strengthen, definitely, provided that's what you need to be doing. But then, you know, closer to that delivery time, we're looking at perineal massage, further into your push technique.
So let's talk a little bit about evidence in terms of perineal massage, because I think that's particularly important for women to understand, and also perhaps also describing what we need to do.
Yeah. So perineal massage is recommended to be started from that 34 to 36 week time span. Only 2 to 3 times a week, 5 to 10 minutes at a time. But you're just trying to stretch that superficial skin and tissue at the entrance to the vagina, and that has been proven to reduce the risk of an episiotomy by 21%, and a severe tear, which is a 3rd or 4th degree tear coming into more of that musculature around the anus, by 64%.
I think that's important, and a lot of women don't know that. And it's also one of the other things, you know, I remember when I was training as a young junior doctor in obstetrics and gynecology, this whole notion, there was 2 different schools of thought: a hands-off technique when the baby's head's coming out, or alternatively a hands-on technique where you're trying to prevent the baby's head from coming out. But in actual fact, there's also an additional point, which is perineal massage during the birthing process as well. So a lot of women, and I'll always ask permission, I always say, look, are you okay with me doing an internal examination and putting a bit of pressure down there doing a perineal massage? Because at the time of giving birth, as that baby's head's coming out in between contractions, if I'm doing a perineal massage, as well as you having also done that during your pregnancy, I'm going to also help reduce that chance of a tear or alternatively a requirement for an episiotomy. And you know, I'm also reminded of the fact that if you do need assistance, so there's a vaginal birth, there's an assisted vaginal birth, and there's a cesarean birth. If you do need assistance with your birth, whether it be a vacuum or alternatively a forceps, that we don't necessarily need to have I like to call it an episiotomy as opposed to episiotomy, because we're appeasing the skin. We don't want to tear. We're sort of releasing the skin so it doesn't tear towards the bottom and cause an issue with the muscle surrounding the bottom and incontinence.
But is that just having a skilled obstetrician?
Well, it also is it's not so much a skilled obstetrician. I think some obstetricians just do it routinely.
Yeah,
every woman needs to do it, and they, rather than doing it when it needs and has to be done, they're doing it just preventatively, and I don't think that's the way to practice, but that's just me personally. So part of that is also doing the perineal massage at the time that the baby's being born.
How do you find when you start that conversation? Do people go, oh, I'm happy to do that, or how can I reach? What do I do?
Generally, most people have heard about it.
Yes.
Whether that's been through a birth ed course, a friend or a sister or someone else they've heard of speak about it.
What do you think about the epino?
I don't love it.
Yeah. Just explain to our listeners and viewers out there what an epino is.
My understanding is it's something that you insert into the vagina, that you inflate, and then you basically practice birthing that epino.
Yeah.
I think we know that risk factors for pelvic organ prolapse are multiple births. Therefore, why practice continuously birthing?
Yeah, I agree. And I liken it to having a rubber band. And if you just continually stretch that rubber band, I mean, it's going to become quite loose and not elastic anymore.
I mean, I'm not sure what I don't think there's been enough research into what the long-term impact of it is.
Yeah, absolutely. And worse still, I have heard people get a second-hand epino, and I don't think that's, I don't think that's really appropriate either.
Did you just like clench your pelvic floor? Just
a little bit tightening of the legs.
I just watched you do that, and you're like, oh, that doesn't say.
I don't think that should be shared.
No, but I think
that doesn't
definitely perineal massage, as you said, a couple of times a week.
Yeah.
and also a perineal massage at the time of birth.
Yeah.
Well, people also say, oh, it's too late. I've left it too late. Have they left it too late if they hit that 38? Like, obviously, but would you still recommend to?
I'd still start it.
Yeah.
It's just the evidence is based off starting it at that 34 to 36 week mark. But
because everyone always worries that they've done something of their way, or they've caught on.
My hope is that they've already been doing their pelvic floor exercises before that, as I've instructed them to, which is also helping to improve the range of motion through the muscle.
Yeah.
Therefore, helping to reduce the risk of tearing.
Libra comes in a range of pads from a liner with double 2-in-1, invisible, ultra thin, maternity, and extra protect.
My number one tip for your hospital bag is Libra maternity pads.
So we've had the baby.
Yep.
And obviously there's going to be a whole lot of changes. What can women expect in those first few weeks, a month afterwards? And when should they be re-engaging with you in order to sort of help them that with transition period after birth?
So personally for me, I often love to check in around that 2-week mark postpartum, so relatively early, but that's normally just a chat rather than actually like a physical assessment, particularly for anyone who's birthed for the first time. Maybe they've had an unplanned Caesar in the end, and that's trying to work through, okay, well, how are you feeling? What are you feeling?
Yep.
And kind of re-kicking in sort of what's happening with pelvic floor, what's happening with ab separation, and starting that rehab process sooner rather than later.
Or not being able to hold.
Yes, maybe
post-birth.
experiencing some leakage.
Yeah.
Maybe you're not getting the urge to pee if you've had a catheter in. I think, I suppose traditionally we'd follow up around that 6-week mark where you do more of that physical assessment again. But at 6 weeks, there's almost so much time that you could have actually, slightly changed the bowel routine or worked on a few things around bladder that have made a really big impact. Or maybe they kept walking, they felt that sense of heaviness and they just thought that was normal and kind of pushed through it. But actually we'd know that we'd want to be prioritizing a lot more horizontal rest in those early days.
Yeah. So what happens if a woman is in her 50s and she's like, achoo! And she's like, oh my goodness, can you fix that?
Yes. I mean, that's probably a loaded question, but
Yeah.
yes.
It's not, people, like they'll say, that's normal. And I'm like, it's not normal to sneeze. And,
common, but normal. Not normal.
Or to jump on the trampoline with your kids and go, uh-oh.
Yeah. So I think obviously pelvic floor strength comes into that.
Yes.
And how much power do you have in that muscle? So power is how strong can it switch on and how quickly does it switch on.
Okay.
And that's obviously trying to work against an increase in abdominal pressure that you'd get with a cough, with a sneeze, jumping on the trampoline. But that might also have more structural impact. So is there a little bit more mobility through the bladder after birth? Is it that you're actually just really constipated, so you've got all this pressure internally pressing against your bladder? So trying to work out what's happening at that 50-year-old age bracket. You're probably thinking, okay, well, what's happening to your estrogen levels? Are they influencing what you're experiencing at the moment? So definitely, again, a lot of areas that you sort of problem solving to be like, what's your biggest contributing factor to your leakage?
There's been really interesting insights, aren't they? Because I think the pelvic floor, again, a bit like periods in our previous episode, many women don't understand their pelvic floor. They don't understand that interrelationship between things like endometriosis and the pelvic floor, and also what we can do throughout pregnancy and the postpartum period, and even up until the ripe old ages of 50 and 60 and 70 in order to help with issues that have arisen throughout our reproductive lives as women.
I mean, I definitely call it generally it's a black hole until people come and see a pelvic floor physio.
It's a black hole.
Just something that they disassociate with, not really any idea about how to do it. I think the most common time that people, aside from in the car, is like sitting on the toilet trying to stop their flow of urine. Some women can do that. Some women, they just slow the flow rate, but ideally you're not doing that.
So what are you meant to be doing?
In terms of how to switch on your pelvic floor?
Yeah, are we stopping? Are we slowing? What are we doing?
You'd want to be able to stop the flow of urine, but in women, your urethra is really short. So consistently stopping and starting the flow of urine on the toilet can increase your risk of a UTI. So generally not the greatest place to be doing your exercises.
Yeah.
Can you switch on your pelvic floor?
You've tried.
Hey, thanks for the wonderful episode. insightful as always. And where can people find you?
So I work out of Epworth alongside yourself, but you don't necessarily have to be a patient of yours to come and see me. So I'm, working out of Epworth. I'm called Sense Physiotherapy.
Tell us a little bit about why we called ourselves Sense.
Sense. Well, sense is actually derived from the word matrescence. I'm pretty sure it's a relatively new word in the Urban Dictionary. But matrescence means the social, emotional, and physical becoming of a mother.
Oh,
I know.
Matrescence.
Wholesome.
it's so wholesome.
Well, thanks for your time today.
Thanks for having me.
No worries. Doula and the Doc, hosted by Vanessa Salerno at Perth.
Can we just put in the bloopers at the end?